The fact is we just don't have enough hospital beds. We used to have something like 300,000. We went down to 140,000. Here we are. The government says, oh, we're going to give you some more hospital beds. One of the things, and perhaps you can just highlight for people, is if you don't have beds, you can't move anyone from A&E because there aren't any beds. If you haven't got any beds in A&E, you can't get them in from the ambulances, and so it continues.
Yeah, you're absolutely right. And I absolutely hate the term bed blocking, because it's not people who blocks beds, it's lack of places to send them. Of course, this goes beyond even hospitals. We've got a huge shortage of social care places for people to go after they're well enough to be discharged from hospital, but they can't leave, so they stay in the hospital beds, so people can't get in from A&E into the hospital beds because they're full, and people, as you so rightly say, can't get in from hospitals. And we're now in a position where GPs are having to write letters, open letters to their patients saying, please stop sending us death threats, because GPs are getting the brunt of the people who can't get the care in hospitals.
So NHS England said its promise was to have 94,500 core beds. Core beds, 94,000 seems an incredibly low number when we have a population of 67 million people.
And you're absolutely right. So if we look at how we've done in the UK compared to other countries over recent years, you're quite right that the number of NHS beds, and we're just talking about England now, has more than halved. In the last 30 years, it's gone down from about 299,000 in 1987 to about 141,000. But that's all the beds. So this here, we're talking about the major hospital acute beds. So that's gone down from 100,000 to 97,000. And I think what's really worrying is that the figures say that 93% of those beds are occupied. Now you'd think, oh, that's all right, we've got 7% of beds you can put people in. It doesn't work like that. You can't move somebody from a care of the elderly ward to a children's ward. You can't move somebody from a surgical ward to an intensive care bed, and vice versa. So the safe bed occupancy is about 85%, and yet we're consistently running at about 93, 94% last year, 93% this year. And by contrast to other countries, we have the second lowest number of hospital beds of any nation in the OECD. In fact, we have under half the average of number of beds per 1,000 people.
And of course, as you know only too well, that's why managers spend their time actually trying to find beds to allow people to be admitted into wards, because there simply aren't the beds available. Now, the clever people at the NHS say, aha, but we also have virtual wards. That means we've got people at home and we can monitor them through telemetry. But that is no substitute for acute medical beds.
Unfortunately, in some cases, of course, people can be cared for safely at home, and for some people it works really well. But of course, you need to have the staff to do that. And my experience is very much that there will be gaps in the staff for the community teams, the specialist teams. And who does that fall on? The GP. And you can't get hold of your GP because your GP is already working a 14-hour day, and there just is no capacity.
And colleagues of mine who are GPs also increasingly frustrated with the length of their days and what they're trying to do. And of course, what the impact of that is, if you can't see the GP, people then go to A&E, and so it continues.
Absolutely. And of course, the sadness is that on the whole, people have a very good relationship with their healthcare professional once they get in to see them. But increasingly, for instance, we're being prevented from referring people. I can say, OK, I think you need to be seen in hospital. I'm no longer allowed to refer you. When I first became a GP, if I said you needed to be seen in hospital, you were seen in hospital. Now we have these things called advice and guidance lines, which mean me writing a letter to a nameless hospital doctor somewhere. I then get a reply a few days later. Often that'll say, oh, can you do these other tests? And I'll look at it and think, no, I'm not skilled to do those tests. I don't have access to those tests. I physically can't do those tests. So I write back. And in the meantime, who gets it in the neck? The GP and the GP.
So why have we had this additional level of bureaucracy imposed upon us?
Well, the theory is, of course, that they're trying to reduce the number of people who are being referred into hospitals. And the easy way to do that is to reduce the number of people that GPs refer. But the problem with that is, if I think somebody needs referring, it's because they need referring. They need to be seen. They're in chronic pain. They might have cancer. I mean, they've even started putting some barriers in the way of us referring people who have signs of cancer to hospital. We have to do additional tests before we're allowed to refer them in.
And it just seems to me, here we go again, another year. Oh, look, it's a surprise. It's winter. We need more beds.
Yeah, I mean, they had plenty of time. When this was announced in January this year and they promised an extra 5,000 beds before winter, they did it in January because we know that come October, November time, we are going to have a winter beds crisis. We're now working in general practice at the same rate all year round that we used to work just in the peak of winter, and the same thing applies to many hospitals. So if we end up having a spike in flu admissions, in pneumonia admissions from pneumococcal disease, in COVID admissions, then of course it's just going to get unsustainable again.